Depersonalization manifests as a form of disconnection within oneself, whether in relation to one's mind or body, or in the sense of observing oneself from a detached perspective. This can induce an unsettling feeling of being on autopilot, or a loss of a strong sense of individuality or self. The affected individual may perceive their world as diminutive, illusory, and somewhat abstract, akin to observing reality from the outside in. In a more perpetual context, this is recognized as depersonalization derealization disorder, a specific dissociative disorder indicated in the Diagnostic and Statistical Manual 5 DSM-5. This condition often characterizes a range of dissociative disorders, including a split personality disorder. Notably, sporadic episodes of depersonalization and derealization could occur in regular individuals experiencing temporary anxiety or stress, but frequent episodes tend to be associated with those who have been subjected to significant trauma or chronic stress anxiety. Depersonalization. Derealization is a cornerstone symptom within the spectrum of dissociative disorders. Moreover, it also features conspicuously in various non-dissociative disorders such as anxiety disorders, clinical depression, bipolar disorder, schizophrenia, personality disorders, migraines, sleep deprivation, and certain types of neurological seizures. In the context of social psychology, and specifically in self-categorization theory, depersonalization signifies the stereotypical perception of oneself as an example of a defining social category. Such individuals might feel a disconnect from their own self, considering their emotions, feelings, behaviors as alien to their identity. This could elevate their anxiety levels, further compounding their perception. Depersonalization and derealization represent distinct but interrelated constructs. The subjective experience of unreality in oneself, depersonalization, and the sense of unreality in the external world, derealization. Some experts still contest the need to see these as independent entities. Depersonalization can be a symptom of several conditions such as panic disorder, sleep deprivation, migraines, epilepsy, severe stress or trauma, anxiety, and the use of certain recreational drugs, including cannabis, hallucinogens, ketamine, and meth. Interestingly, it can also emerge from certain types of meditation, deep hypnosis, extended episodes of mirror or crystal gazing, sensory deprivation, and head injuries resulting in loss of consciousness. The concept of ipsity disturbance, a term borrowed from Latin meaning self or identity, is said to be at the heart of schizophrenia, spectrum disorders. It manifests as a disorientation between self and others or the world, such that they may appear indistinguishable, or conversely may assume an exaggerated significance relative to the objective or intersubjective world. Viewed as a construct, depersonalization can be evaluated and measured, with scales now developed to plot its dimensions temporally and spatially. Interestingly, depersonalization and derealization were found to significantly escalate after experiences of uncontrollable stress, such as semi-starvation, sleep deprivation, and loss of control over hygiene, movement, communication, and social interactions among the military trainee. Notably, depersonalization is recurrently reported as an effect of recreational drugs, something that some users seek, as well as caffeine, alcohol, amphetamine, cannabis, and antidepressants, among many others. The chronic depersonalization symptoms have been observed in people with long-term dependence on benzodiazepine, even those on a steady daily dose, chronicling as a protracted feature of the benzodiazepine withdrawal syndrome. Lieutenant Colonel Dave Grossman, in his book On Killing, hypothesizes that military training deliberately inculcates depersonalization in soldiers to make it easier for them to kill their adversaries without being hobbled by empathy. Interestingly, Graham Reed postulated in 1974 that depersonalization could be tied to the surreal experience of falling in love. It is also a frequent psychosomatic response to acute trauma, evident in victims of motor vehicle accidents and imprisonment. From a psychological standpoint, depersonalization, much like dissociation, can be interpreted as the mind's instinctive strategy for voiding an uncomfortable experience, ranging from mild stress to extreme conditions like chronic anxiety and post-traumatic stress disorder. However, due to its indiscriminate nature, it tends to mute the intensity of all experience, not just the unpleasant ones, leading to a sense of disconnection with the world and lending a pallid hue to one's perception of reality. The path to recovery is fundamentally shaped by the root cause of the ailment. It may either be physical or mental. In cases where depersonalization arises from neuropathy, the initial course of action gravitates towards identifying and managing the specific ailment diseases like ALS, Alzheimer's, MIS, or any other neurological disorders impacting the brain often present depersonalization as a cognitive symptom. For patients exhibiting both depersonalization and migraines, tricyclic antidepressants are the usual prescription. When the root cause of depersonalization is psychological, for instance, developmental trauma, its treatment is based on the diagnosis. Treatment of conditions such as dissociative identity disorder or DDNOS, brought about by intense developmental trauma fracturing the formation of a cohesive personality, necessitates comprehensive psychotherapy in the presence of subordinate disorders like eating disorders. A team of specialists is required to manage the patient. Depersonalization is also symptomatic of a borderline personality disorder that can be managed long-term through suitable psychotherapy and psychopharmacology. Depersonalization disorder encompasses the treatment of chronic depersonalization. A 2001 Russian study demonstrated that naloxone, a drug countering the intoxicating effects of opioids, could effectively treat this disorder. By the findings of the study, naloxone therapy eradicated depersonalization symptoms in 3 of the 14 patients, and 7 patients exhibited significant improvement, reconfirming the vital role of the body's opioid system in the development of depersonalization. The anti-seizure medication, lamotrigine, has been seen to ameliorate depersonalization symptoms, and it generally used with a selective serotonin reuptake inhibitor. It is thus the first choice of medication for the Depersonalization Research Unit at the King's College, London. The Institute's researchers, stationed at the Institute of Psychiatry in London, use the term DPAFU, depersonalization and feelings of unreality, to indicate the disorder. Vasuna and his team, in their 2020 article published in the journal Nature, put forward experimental evidence that layer 5 of the retrosplenial cortex could induce dissociative states of consciousness in mammals.